Hello, my name is Thomas Mawson. I'm a cardiologist at Columbia University Irving Medical Center with a clinical focus on echocardiography and prevention. And I'm going to be talking about managing aortic stenosis and mitral regurgitation. I have no financial disclosures. The objectives of this talk are to identify some of the signs and symptoms of valvular heart disease in older adults, to review current treatments for aortic stenosis and mitral regurgitation, and to describe a few novel therapeutic options in an older adult population. So to start with, I want to emphasize that valvular heart disease continues to increase in prevalence as the population ages, particularly aortic stenosis and mitral regurgitation. Symptomatic aortic stenosis and mitral regurgitation are associated with heart failure, arrhythmias, and excess mortality. And both of these are primarily mechanical problems, with medical therapies really having limited effectiveness. This is particularly the case for aortic stenosis. The good news is that minimally invasive therapies, mechanical solutions, are becoming more common in older adult patients. Now, I want to emphasize a couple of things about valvular heart disease. One is that in thinking about treatments, patient selection is key in an older adult population. You're taking into consideration someone's life expectancy, their frailty assessment, the severity of their current symptoms, and the overall goals of care. The goals of therapy in intervening on symptomatic valvular disease, including improving quality of life, maintaining functionality and a patient's independence in the community, palliation of severe symptoms, and in selected patients, a mortality benefit. The big picture I want to emphasize includes a few things. One is that aortic stenosis in particular is really a disease of the elderly, and our most effective therapies really are now widely used in older adults and adults with very advanced age, even in their 90s or 100. Um, Aortic stenosis is significantly easier to diagnose as a general rule compared to mitral regurgitation as a cause of a patient's symptoms. And for aortic stenosis, transcatheter aortic valve replacement, which I'll talk about more, is now widely used in older adults with immediate and often dramatic quality of life benefits. For mitral stenosis, I would emphasize that cardiology input is often key in determining how severe it really is and assessing whether it's the cause of a patient's symptoms, whereas with aortic stenosis, it's often a bit more obvious. For mitral regurgitation, it's key to distinguish between a primary versus a secondary cause of mitral regurgitation. I'll talk more about what that means. And while not as widely used as TAVR currently, there are expanding transcatheter options for mitral regurgitation. There are also actually some minimally invasive surgical options that I'll talk more about. The guidelines that underlie what I'm talking about today really are the 2020 ACC/AHA guideline for the management of patients with valvular heart disease, and I'll refer to that a few times. This is a document that has a lot of good content in it, and I encourage you to take a look at it if you have questions about this topic. To start with aortic stenosis, the normal valve area for the aortic valve is around 3 to 4 centimeters squared. Symptoms generally develop when the valve area has become less than 1/4 of normal area, and traditionally we use a cutoff around 1. There are a few different causes of aortic stenosis, but I'm going to be focusing on valvular aortic stenosis. This is generally what people mean when they say aortic stenosis or AS. So there's a few causes of AS, but by far the most common, especially in an older adult population, is calcific aortic stenosis. What this involves is over years, calcium deposits on the valve leaflets. This leads to thickening and restriction of the valve leaflets so that they're barely opening with each beat. And this is what it looks like in a surgical explant. As the valve becomes tighter, this affects the flow of blood to the rest of the body. It leads to increased pressure within the left ventricle, and it causes a classic set of symptoms. People can have exertional dizziness or syncope. They can have angina, just the same as angina from coronary artery disease. They can have dyspnea or clinical heart failure. Symptomatic aortic stenosis is also associated with sudden cardiac death. The onset of these symptoms has been known for many, many years to have a association with a dramatic change in the mortality curve for aortic stenosis. Patients can live for a number of years with mild or moderate aortic stenosis without any symptoms and without a dramatic change in their mortality risk. But once symptoms develop, mortality increases dramatically. This is from a recent overview published in JACC Advances just this year, which, among other things, noted that aortic stenosis is associated with excess mortality across a spectrum of severity, but most dramatically in severe symptomatic aortic stenosis. So, this is in general a progressive disease. This calcification and restriction of the valve tends to slowly get worse. Certain factors are associated with more rapid progression. As you can see, these are common ASCVD risk factors. And median survival once symptoms develop can be as little as 1 to 2 years, particularly with heart failure symptoms. Physical exam, the classic finding is a murmur with a crescendo-decrescendo profile. When AS becomes severe, it's important to know that the murmur does not become louder. In fact, it often becomes quieter as aortic stenosis becomes more severe. But the murmur peaks later during the cardiac cycle, and often the A2 sound may be obscured or absent in severe aortic stenosis. You may also find delayed pulses in the carotids or peripherally. You may also hear an S4 or feel an LV heave. I would say the key finding really is the presence of a new murmur, particularly with concerning symptoms, that will then trigger you to get an echo. Echo is really the cornerstone of confirming the diagnosis or making the diagnosis of aortic stenosis and determining the severity. There are a few other ways we can determine severe aortic stenosis, but I'm not going to get into those too much. And the criteria are relatively straightforward. We're first of all doing a visual assessment of the valve, and this is key. For me as a cardiologist, if I'm looking at a valve and it's opening really well, if the other numbers aren't making sense, I'm not going to say the patient has severe aortic stenosis if it's clearly opening normally. If the patient has elevated velocities across the valve, if they have an elevated pressure gradient, those can be seen with aortic stenosis, and we can estimate the valve area in a few different ways. Other than this most classic type of aortic stenosis, there are some more complicated situations. Basically, what we're seeing in the traditional criteria is that the heart is pumping against a fixed orifice. This leads to increased afterload against the heart, increased resistance to flow, and that leads to higher pressures within the left ventricle, causing higher velocities through the orifice and a higher pressure gradient. But that won't necessarily happen to the same degree when you have less flow across the valve. Classically, we see that when someone has heart failure with a low ejection fraction. Because the heart is pumping weakly, there's less flow across the valve, there's lower pressure during systole in the left ventricle, and that leads to lower than expected velocities and pressure gradients, even though someone may have severe AS causing symptoms. That is traditionally what we mean by low flow, low gradient AS. There's also another type of low flow, low gradient AS that often may be seen in older patients, particularly older female patients, where you have a low stroke volume, for example, because of left ventricular hypertrophy with a small cavity. And that low stroke volume also leads to low flow across the valve and lower pressure gradients, lower velocities. In these situations, it can be really key to have cardiology input to help suss out if someone really has severe aortic stenosis. Now, how do we medically manage this? The bottom line is we don't really have effective options for medical management. It is a mechanical problem with a fixed obstruction, and we don't currently have any medicines that either relieve that or prevent the progression of aortic stenosis. For a time, there was a lot of interest in the idea that statins might slow the progression of aortic stenosis, but unfortunately, that didn't seem to pan out in trials. And current guidelines have this as a class 3B, basically saying this is not effective. So, perfectly fine to use statins in patients with aortic stenosis, but it would be for all the usual reasons of secondary prevention for coronary artery disease or primary prevention in a patient with an appropriate risk profile. The other thing that's important to think about with medicines is blood pressure control. Often, as AS becomes severe, the blood pressure starts to drop, and a patient may need de escalation of their blood pressure regimen. Now, if someone has significant AS and they're hypertensive, that doesn't mean that you don't treat it, but you want to be cautious about how you lower it. And particularly if someone has severe aortic stenosis, I think the priority really is to get them treated when they develop symptoms rather than aggressively lowering their blood pressure. Again, the main takeaway, there are no medicines that currently prevent the progression of AS. The only other thing I'll mention as a sidebar is in recent years, there's been a lot of interest in lipoprotein little a and the association with more rapid progression of aortic stenosis. There are current therapies that are in trials and hopefully becoming available in the next few years that have been shown to dramatically lower LP little a levels. So it's currently under investigation to see whether this will slow the progression of AS. So stay tuned in the coming years. Now, if a patient has aortic stenosis, when should you refer them to a cardiologist? If someone has severe aortic stenosis, they should always be seeing a cardiologist. Um, if they are symptomatic, it's semi-urgent, I would say, because as we've seen, that's associated with significantly increased mortality, regardless of the symptoms. It doesn't mean they have to be immediately referred to the ER, but you want to get them seen in the coming weeks, I would say. If someone has moderate aortic stenosis, I think it's important to send them to a cardiologist, not necessarily urgently, for a few reasons. One is just for closer surveillance, and so when they do develop symptomatic severe AS, they're already established with a cardiologist. The other reason is sometimes a patient can have quote unquote moderate AS based on our traditional cutoffs, and it's actually severe for other reasons. So if a patient has moderate aortic stenosis and new symptoms that you're concerned about, it's certainly reasonable to send them to a cardiologist. Now, with mild aortic stenosis, I would say it's a little more complicated. In general, if you know and are comfortable with the typical surveillance by echo for mild aortic stenosis, I'm not sure a patient necessarily needs a cardiologist as long as you're getting that echo every 3 to 5 years and you're aware of the symptoms that you should be concerned about. But I think it can be reasonable in certain situations. One, if a patient has symptoms that you're concerned about. Two, if a patient has other structural heart disease and it's possible that maybe their AS is more severe than their echo might suggest. Um, and three, just if where you practice, there are very long delays in getting someone established with a cardiologist. Now, getting a little bit into management. For the patient who is asymptomatic, what do you do? There's, at this time, a class 2A recommendation to do exercise testing. This is useful for a couple of reasons. Even in severe aortic stenosis, it's generally low risk if a patient doesn't have symptoms. And this gives you a very monitored setting in which to, one, determine if they really are asymptomatic or not, and two, establish a baseline for their functional status. Oftentimes, patients will say they don't have any symptoms who are perhaps sedentary, and when you put them on a treadmill, you find that they are clearly symptomatic. They may have evidence of ischemic changes as a result of aortic stenosis, or they may have certain high-risk findings like hypotension with exercise. Now, when do we actually intervene? Currently, the class 1 recommendation in the 2020 guidelines is for severe symptomatic aortic stenosis. That's pretty straightforward. Asymptomatic severe AS when the ejection fraction is under 50%, or if a patient has another indication for cardiac surgery, like they're undergoing bypass surgery for coronary artery disease. If they also have severe AS, you're going to fix it. You're also going to do that if they have moderate AS and they're getting other cardiac surgery. Now, the current guidelines do have some 2A recommendations for asymptomatic severe AS. The first is based on surgical data from South Korea that came out in the last few years, showing that very severe AS appears to have a benefit to intervention. And that's based on, for example, a very high peak velocity. Often in practice, patients with these numbers that are so bad are typically severe. Another indication can be if patients have severe AS, they're low operative risk, and they have evidence that the AS is starting to cause injury to the ventricle based on certain biomarkers like B-type natriuretic peptide. The last reason can be if they have severe AS that has rapidly progressed, even in the absence of symptoms. Now, one thing I want to talk about briefly that is new in the last year is related to asymptomatic severe AS. The FDA recently approved the use of several different transcatheter valves that have previously been used for symptomatic severe AS, now in asymptomatic populations. And that's really based off of one trial that came out in the past year. The early TAVR trial was a multi-center randomized controlled trial of 901 patients published in the New England Journal of Medicine with severe aortic stenosis, no symptoms, comparing TAVR up front to clinical surveillance. All of these patients on enrollment had to get a treadmill test to confirm the absence of symptoms. The mean age for this population was 75.8 years, again reflecting that AS is a disease of older patients. And the primary endpoint was a composite of death, stroke, or unplanned cardiovascular hospitalization. I want to emphasize that for the patients who went to clinical surveillance, if they progressed to symptomatic severe AS, they would be treated based on current guidelines with aortic valve replacement, generally with TAVR. In this case, they wouldn't be surveilled with symptomatic severe AS. So in this trial, this was a positive trial. They saw a 19% absolute risk reduction, which is quite dramatic, with a hazard ratio of 0.5 for their primary composite endpoint. But this was primarily driven by the endpoint of fewer hospitalizations. You can see over here on the right the curves for the composite endpoint and for the individual components of that composite. There was a numerical reduction in stroke from 9.5% to 5.4% with TAVR, which did not quite meet statistical significance. And there was slightly numerically lower mortality without any statistical significance, but there was a dramatic reduction in unplanned hospitalizations with a hazard ratio of 0.43. Now, on the one point, this is not evidence yet of a mortality benefit. On the other hand, there can be a big difference between a planned procedure where a patient gets a series of studies as outpatient, comes in for their procedure, and has a brief hospitalization, compared to an unplanned hospitalization where someone perhaps is having severe symptoms, is in decompensated heart failure, and maybe has a more complex or longer hospitalization. That can be particularly problematic in a patient with advanced age, where we're all familiar with the harms associated with hospitalization and length of stay. There hopefully will be more data coming out in the coming years about TAVR in asymptomatic patients. Part of the reason that the guidelines historically have emphasized symptoms so much was because there was this dramatic change in trajectory, but also because the primary therapy was surgical, which was associated with morbidity. There are a number of clinical predictors of operative mortality, and so obviously we're thinking about in this population minimally invasive options. The therapy that is going to be most salient in an older adult population is transcatheter aortic valve replacement, or TAVR. This is favored in the current guidelines in patients over 80. In the age range of 65 to 80, it's really an assessment by the provider about risks and benefits. TAVR does carry a few specific risks, which are not terribly high risk, such as, for example, a risk of requiring permanent pacemaker implant. I would say one of the biggest issues in thinking about strategy is durability. TAVR valves do have a life expectancy of around at least 5 years, hopefully, often 10 plus years, but it wouldn't necessarily be as durable as certainly a mechanical valve placed surgically. Now, one thing that has become more common in recent years is the ability to, after a TAVR, if that valve becomes stenosed, to do a second TAVR procedure where a new valve is deployed, what's called valve in valve. There are even cases of two valves being implanted sequentially, valve in valve in valve. And this strategy may allow you to get from 10 to 15 or even 20 years with a purely transcatheter approach. Now, there are rare situations where a surgical strategy may be preferred in an older adult population. One example could be prosthetic stenosis, where, say, somebody has a stenosed mechanical valve and you just can't treat that with a TAVR, or a patient has had a series of TAVR and then valve in valve, and the valve is now just too small to put in another valve. This also could be an issue if you practice somewhere where there just isn't access to local expertise with TAVR, although it's now become quite widely used across the country. The last thing I'll say for TAVR is that the initial trials were based on people who were prohibitive risk for surgery or high risk, and subsequent trials have shown TAVR to be non-inferior in across all risk profiles. So it's increasingly widely used, even in low-risk patients. I'm just going to highlight, this is a recent review in JACC Advances, the references down here at the bottom. That is a nice review of TAVR specifically in older adults and some of the specific considerations. The only other thing I'll say about TAVR is it's key to think about in older adult population improvement of symptoms, but we're also thinking about numerical age versus biological age. And a patient, say, who is in their mid 80s, but is robust, active, living independently, and other than their valvular disease, you would have every expectancy of living another 5 or even 10 years. That patient very likely would derive a mortality benefit from treating their aortic valve disease. So it's a holistic assessment of the patient. Moving on now to mitral regurgitation. Mitral regurgitation can present with some of the same symptoms of aortic stenosis, dyspnea on exertion, heart failure. Often, though, it can be associated with new atrial fibrillation as a result of increased pressures within the left atrium. Unlike aortic stenosis, it's less likely to cause exertional dizziness or syncope. The classic finding is a characteristic murmur. This is classically a holosystolic murmur, loudest at the apex, radiating to the axilla. Certain types of structural disease may be associated with specific murmurs like mitral valve prolapse, and the changes in the left ventricle over time, the chronically increased volume load, can cause some other findings like an S3 gallop. Generally, just like aortic stenosis, the key takeaway is a new murmur with concerning symptoms. You're going to get an echo to confirm the diagnosis. When we look at the echocardiogram, we do a qualitative and a quantitative assessment of mitral regurgitation, just like aortic stenosis. We're looking at other features of the left side of the heart, and we're thinking about the etiology of mitral regurgitation, which can be much more varied than aortic stenosis. Other tests like EKG and chest x-ray, I would say more give us clues to mitral regurgitation. One thing I'll mention about diagnosis, particularly in the elderly, is often this actually can be mistaken for a pneumonia. Mitral regurgitation often involves an eccentric jet where the regurgitation is not moving straight back into the left atrium and into the pulmonary circulation, but rather the jet is directed off more to one side. What that leads to is asymmetric opacities on chest x-ray that in a patient with, say, dyspnea and new productive cough can easily be mistaken for a pneumonia. So certainly in a patient who you know has some degree of MR or has a significant murmur, don't chalk up unilateral opacity automatically as a pneumonia. Now, etiology, the key distinction here is primary versus secondary mitral regurgitation. Primary means there's an intrinsic problem with the mitral valve, and I'll talk more about what that could be. Secondary really is the mitral valve leaflets themselves are structurally normal, but one of the adjacent chambers or both is dilated for one reason or another, and that's stretching the annulus of the valve. Because the annulus of the valve is being stretched, the leaflets, even though they're normal, just are not coapting like normal, and that leads to regurgitation. And the way that we treat that in the clinical course may be very different. Primary can be due to a lot of different causes, often particularly in older patients. That's degenerative disease or myxomatous disease, but it can also be from rheumatic disease, endocarditis, calcification of the valve. And I put hypertrophic cardiomyopathy as sort of a sidebar because it can cause mitral regurgitation both due to sort of changes in the hemodynamics involving other parts of the heart, but also the mitral valve itself is usually not completely normal. Now, one thing I want to highlight, again, mitral regurgitation can be much more challenging, even for a cardiologist, to determine how severe it is and to determine if it's really causing a patient's symptoms. I'm exaggerating this a little bit, but on the left, I have the current echo guidelines for grading aortic stenosis. On the right, I have the current American Society of Echocardiography guidelines for grading mitral regurgitation. And as you can see, there are a lot more components, even though there is a lot of quantification and a lot of numbers that we can use. There can be tremendous variability from one study to another based on the quality of the echo, who reads it, and even what's going on with the patient at the time of the study. So the key thing to highlight always is just use your clinical assessment. How concerned are you by the patient's symptoms? If you hear a murmur, you're hearing concerning symptoms, and the echo is read as moderate mitral regurgitation, or you have, say, an outside report, that doesn't automatically mean that it's not mitral regurgitation causing their symptoms, or that maybe it's not more severe. When should you refer to a cardiologist for mitral regurgitation? Certainly for severe MR. Moderate MR, I think it's also reasonable to refer, in part because, as we've said, it's often misclassified. It may in fact be mild, it may in fact be severe. And especially if someone has concerning symptoms, I think it's reasonable to refer for moderate MR. Although, as a general rule, MR can often be tolerated for much longer than aortic stenosis. While aortic stenosis has that dramatic increase in mortality once it becomes symptomatic, mitral regurgitation, or how should I put it? Aortic stenosis, when it's severe, it's often a much more rapid progression to symptoms than mitral regurgitation, which sometimes is tolerated as severe for many years. Mild MR, if the mitral valve is structurally normal, rarely requires cardiology input, and trace MR is completely normal and physiologic. But if there are certain structural abnormalities, such as rheumatic mitral valve or mitral valve prolapse, then it may be reasonable to refer them to a cardiologist, regardless of the degree of MR. Now, how do we manage this? Like in aortic stenosis, this is a mechanical problem, but we do have a little more ability to medically manage MR. One thing I want to go back to is primary versus secondary. If the MR is due to secondary MR from heart failure, oftentimes getting someone on the right heart failure medications, getting their volume status and their blood pressure into the best possible place may dramatically improve the degree of MR. You just have to unload the ventricle and reduce that LV dilation, either rapidly with diuresis or over time with guideline-directed medical therapies for systolic heart failure, and you may see the MR improve markedly. If someone has primary mitral regurgitation, say from mitral valve prolapse or a degenerative valve, you're much less likely to achieve that. I do transesophageal echocardiograms commonly in my practice, and I often see in assessing mitral regurgitation the patient's blood pressure changing during the study and seeing the degree of mitral regurgitation changing significantly during the study, depending on what the cause is. Particularly in an older population where maybe a patient is not a great candidate for any type of intervention, things like controlling excess blood pressure can be critical. Now, what are the indications for mitral valve intervention? The class 1 indication, of course, is severe symptomatic mitral regurgitation. After that, we get into mitral regurgitation that's associated with left ventricular dysfunction based on their ejection fraction, and into some other specific criteria that I'm not going to belabor. It's really echocardiographic criteria, but the basic concept is that the mitral regurgitation is affecting the function and the structure of the left ventricle. The left ventricle over time will dilate and it will then become weaker. You'll have systolic dysfunction, and we want to prevent that. There are some also class 2A indications. Again, I'm not going to belabor these because I think this can be a much more nuanced decision that cardiology is going to be closely involved in guiding. The one thing I will highlight is that if you have an asymptomatic patient with severe mitral regurgitation, everything else is structurally normal with their heart, but you have a good chance of surgical repair at a center of excellence, that is a class 2 indication to treat it. Now, the other thing that I'll get into a little bit is what are the options other than surgery? The current guidelines give a class 2 recommendation for treating MR, both primary and secondary, with what's called transcatheter edge-to-edge repair under certain circumstances. Secondary MR due to heart failure is sort of the classic situation where transcatheter edge-to-edge repair or MitraClip was first characterized. So here, I don't want to get too much into the details of the echo criteria, but I want to just highlight a few minimally invasive therapies that may be attractive in an older adult population. The main surgical option that is minimally invasive is a robotic mitral valve repair. As you can see, a prepped patient here on the left, this involves a mini lateral thoracotomy and the placement of a series of trocars through small incisions in the chest, which are all then removed at the end of the surgery. This is associated under successful conditions with a very short length of stay, sometimes even just several days, and with excellent outcomes. The key here is access to a surgeon who is experienced with robotic mitral valve repair. There are unfortunately a very small number of surgeons around the country and even around the world who are skilled at this operation. Much more widely used are transcatheter options. Transcatheter edge-to-edge repair, or what's called MitraClip, involves entering the heart through peripheral vascular access, going to the mitral valve with a clip that's on the end of a small catheter, and then deploying this clip to essentially cinch the leaflets together. Classically, this was described in the COAP trial, shown to have a benefit in patients where the mitral valve was structurally normal, but there was secondary MR2 to left ventricular dilation. In that case, you could just pinch the leaflets together with a clip or a series of clips and significantly reduce the degree of MR, significantly improve outcomes. This is now, as I alluded to, also started to be used for primary MR. The key here is patient selection, and that's going to be done in collaboration with cardiology. The other therapy that is a little bit newer but is expanding is similar to TAVR, putting in a new valve on a catheter, what's called transcatheter mitral valve replacement, or TMVR. This is not quite as widely used as MitraClip, but it's something that's expanding and technologies are improving. So expect to see more of this in coming years. Both of these are minimally invasive options. This is just to show a little more detail about what a MitraClip or mitral transcatheter edge-to-edge repair, M-TEER, looks like. Entering the left side of the heart with a small catheter and deploying this clip that pinches both leaflets or a series of clips. And it's finding a balance of reducing mitral regurgitation without reducing it so much that you get mitral stenosis. This is what the valve is going to look like after clips have been deployed. That concludes the main part of this talk. I want to just highlight a couple of things. First is that valvular heart disease is a major cause of morbidity, mortality, and day-to-day symptoms in older adults. Treatment can provide significant symptomatic relief, maintenance of functionality, and in selected patients, improvement of survival. The good news is that both surgical outcomes, but also transcatheter technologies, percutaneous therapies, are increasingly widely used in older adults, both high risk and low risk for surgery. That concludes this presentation. I hope that you found this helpful, and thank you for your time.